Hey all, welcome back to the Real Life Pharmacology podcast. I am your host, pharmacist Eric Christensen. Thank you so much for listening today. Go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great no-brainer if you're out in practice, if you're taking pharmacology courses. We've got some of the most highly testable information that you're going to see in there. So simply an email will get you access to that, and then we get you updates when we've got new podcast episodes available and other content as well. So again, reallifepharmacology.com, simply an email subscription will get you access to that. All right, let's get into the drug of the day today, and that is spironolactone. Brand name of this medication is Aldactone. This is a potassium-sparing diuretic. Now, mechanistically, how does this work? The other classification is it's an aldosterone antagonist. So it binds where aldosterone is going to bind on receptors and ultimately blocks that aldosterone binding. By doing that, we're going to increase sodium chloride elimination, as well as we're going to increase water excretion. So this is, again, a potassium-sparing diuretic, so it causes some of that water excretion. Now, as you can imagine, potassium is spared, so potassium goes back into the bloodstream, and that's why we can have elevated potassium levels with this medication. So that's how the drug works. Now, what conditions, disease states do we use this medication in? So first and foremost, it is classified as an antihypertensive, so you may see it for that. Usually it's a little bit more refractory cases. So for instance, you're usually going to see your calcium channel blocker, your thiazide diuretic, and maybe an ACE or an ARB inhibitor, an ACE inhibitor or an ARB. Those are really going to be the go-tos. But if you get down the road where we're still struggling to manage hypertension, or we've had intolerances to those other medications, that's where you may see spironolactone in play there. Other diagnoses, so edema and swelling from CHF, ascites, so those are two important indications. With ascites, I did want to mention that for that, abdominal fluid loss, it's often used in combination with furosemide, and the ratio on that's used together is 100 milligrams of spironolactone to 40 milligrams of furosemide, and that's done so to kind of level off that potassium. Furosemide is going to kick out potassium from the body, and spironolactone is going to cause that potassium sparing effect. So to kind of even out that potassium, that's typically the ratio that's used. Now, obviously, we're going to pay attention to patients. We're going to monitor them clinically and by checking labs and that sort of thing. And it may need some adjusting and tweaking from there, but that's kind of a little bit of a rule of thumb with the dosing of those two agents together in ascites. A couple other things, definitely less common. So female hair loss is one. Acne is another one as well. Remember, this medication does have some anti-androgenic effects, which, certainly that could contribute to some acne. So that's why this medication it can be helpful in that setting there as well. Usual dosage ranges, 25 to 100 milligrams, maybe up to 150 milligrams. I would say the most common situation I see, we're in that 25 to 100 milligram dosing range. Heart failure. So there is some specific guidance with regard to heart failure and using spironolactone, and it's in relation to renal function and potassium. So it's recommended to avoid use in patients with an eGFR of less than 30 for heart failure patients. And if you've got a patient that has a baseline potassium of 5 or more, it's also recommended to avoid spironolactone. It could certainly worsen both of those situations. All right, so let's dig into adverse effects a little bit more deeply. So first and foremost, probably the classic test question, if you're in pharmacology classes in school, that sort of thing. Spironolactone can cause gynecomastia. So basically enlargement of male breast, man boobs, you may hear it referred to as far as a non-medical term. And obviously this is an adverse effect that probably doesn't happen overnight, right? I mean, that wouldn't make a ton of sense. So it's associated with higher dosages and a longer duration of use. We're more and more likely to see that. So and doses above, at or above 150 milligrams, that's where you're more and more likely to see it, which, is why one of the reasons, I guess, why we try to limit that dose to less than 150 if possible. All right, other adverse effects, elevated potassium. So patients who are at risk for that are a lot of people in the population that I work with mostly. So older age, they might have some renal impairment. They're on other meds, ACE inhibitors, ARBs, maybe even NSAIDs that can increase that potassium or that hyperkalemia risk. If they've got a baseline potassium that's already, upper end of normal, that's another situation where we may increase that risk for hyperkalemia, and obviously bad things to happen because of that. Other adverse effects, spironolactone, it's going to lower blood pressure, so orthostasis, dizziness, that's kind of a no-brainer. Diuresis, I kind of alluded to, so increase in urinary frequency is something I've certainly seen happen. And with that, the prescribing cascade, if you see, let's say, urinary anticholinergic being used for urinary frequency, let's try to make sure that we're not causing that by using excessive diuretics and things of that nature. So definitely pay attention to that whenever you hear a patient ask for a medication to reduce urinary frequency. Be sure to assess other meds that may have diuretic effects. Erectile dysfunction and sexual adverse effects are possible as well. And then from an electrolyte standpoint, obviously I alluded to elevations in potassium, but it kicks out sodium. So hyponatremia can happen, lower magnesium levels can happen, lower calcium levels can happen on account of spironolactone. All right, let's take a quick break from our sponsor and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material like BCPS, ambulatory care, BCMTMS, geriatric exam, or the NAPLEX, go check out meded101.com/store, S-T-O-R-E. We've got a growing list of resources there that will definitely help you prepare and pass your board exam. If you're another healthcare professional, dietitian, for example, we've got a book on food-drug interactions. If you're in primary care, we've got a great book on drug interactions in primary care. Nursing, we've got pharmacology crossword puzzle book. That's definitely interesting. Lots of different stuff. Flashcards, also audiobooks as well. So please go support the sponsor. Any purchases there directly help keep this podcast going. So certainly appreciate it. The link, meded101.com/store, S-T-O-R-E. All right, so let's wrap up with drug interactions. So first and foremost, potassium elevating medications. So ACEs, ARBs, your ARNI in heart failure can often be used with spironolactone in that situation. So obviously recognize those and monitor potassium levels. A few others that you may not think of quite so much, cyclosporin, tacrolimus, so those are immunosuppressive type agents. Rarely, if you got a patient on chronic heparin products, like enoxaparin, for example, there is some association with hyperkalemia there. NSAIDs, not something I get crazy worried about usually, but there is potentially some associations there with hyperkalemia when used in combination with other drugs that can do that. And then last but not least, I want to mention trimethoprim. I have seen this medication cause a significant hyperkalemia in a patient taking other drugs that raise potassium levels. So don't forget that one, often in the combination of Bactrim used for UTI infections, skin infections maybe potentially. So definitely pay attention to that. Other interactions, blood pressure lowering medications, I think that's kind of common sense. Some drugs that aren't considered antihypertensives, Parkinson's agents can lower blood pressure, some of those dopamine agonists. PDE5 inhibitors for sexual dysfunction like sildenafil, those can drop blood pressure. And then on the flip side, think about meds that can raise blood pressure. So stimulants, for example, can directly oppose what we're trying to do there. If we are using these diuretics or spironolactone for edema, swelling purposes and to reduce that, also think about medications that can worsen fluid status. I think of gabapentin, pregabalin, NSAIDs, for example, pioglitazone for diabetes, that can cause some edema and swelling. All good examples there to pay attention to and make sure we're not contributing to the prescribing cascade and polypharmacy in general. All right, well, I think that's going to wrap up the podcast for today. Thank you so much for listening. If you enjoyed this episode, please do us a huge favor. Leave us a rating review on iTunes or wherever you're listening. It's greatly appreciated. Go take the time, support the sponsor, meded101.com/store. A lot of great resources there for something for everybody, for sure. So go check that out. Get a gift for somebody. Support the podcast as well there. If you want to reach out to me, mededucation101@gmail.com. And that is all I have for you today. Thank you so much, and I hope you have a great rest of your day.